progressive and like I'm some kind of bleeding heart social and socialist, progressive, you know, peachy commie or something like that, and then people find out that I'm this kind of conservative believer in Jesus, and you know, short circuit, it doesn't all compute. But for me, it's just frankly doing what I believe Jesus would do, and wanting to be a plumber rather than a janitor, and wanting to do that with people in my community who need it the most. So appreciate the opportunity to share, and don't know if any of you have any questions for a few minutes. I'd be happy to answer them in Spanish, English, or Greek, whichever language you prefer. So thank you. And if there are no questions, I'm out of here. Yes?
I have one question.
Sure.
In a clinic setting where time is brief, what do you think is the most effective way to communicate something that's not just what they've heard 100 times before and will mentally dump when, you know, real life happens?
Two things. I don't want to get into too much detail, but it's very interesting that I think that there is opportunity to make some fundamental operational changes in that at the county over the past several years with some of the community clinics, for example, in this region. We have done some pilot projects where I have been willing to pay for group visits for, instead of one doctor spending 10 minutes each with 6 patients in an hour, why not one nurse practitioner spending an hour with 6 people at once and having like a therapeutic, if you would, transformational health network? And so I think part of the whole concept of a team-based approach and care coordination means that the focus of the medical quote-unquote encounter is not just what happens when you're face-to-face with a provider, but that there's a greater sort of emphasis on comprehensive education. And I also believe in peer networking. It was C.S. Lewis who said, true friendship begins when one says to another, what? You too? I thought I was the only one. And patients can experience that as well. And I think with their appropriate consent, harnessing the capacity of, again, support groups, and to use those to replace potentially, or at least supplement, the opportunity. Who says that the model of seeing one person at a time for 12 minutes is adequate versus the potential of doing some of that educational repetition stuff as part of a small group? So that's one quick thought. Number 2, I personally chose family medicine with the intention of establishing rapport and ongoing relationship with people so that I could build, and I actually, back in the day when I was a full-time doc taking care of sick people, I still had a paper chart. We don't have that anymore. But there are still little ways that you can kind of leave yourself little messages in terms of where you are in the process of talking of people or developing rapport. Look, you know, to me, part of what we can serve as healers and part of what I think, frankly, NPs are better than physicians at doing is to establish rapport and relationship with people that allows for marination of their hearts and greater receptivity to have input over a longer period of time. Thirdly, authenticity. I think so many of us just go into cruise control. And I just have found that, yes, there are issues related to parameters and boundaries and so forth, but I've always kept it real. I don't know if you noticed up front when I put the intro slide up, Dr. Nick was with a little d. That's kind of my thing. I've always been little Dr. Nick, and I don't even go by Dr. Efantides, just to kind of be a little bit more informal, because I don't want to take myself too seriously. And I would rather my people think of me as their advocate, as their partner, rather than as their doctor or their, you know, wizard of white coat. So all of those things combined, and honestly, compared to other parts of the country, the last thing I'll say, and it's significantly a bummer, we don't have any quote-unquote faith-based health outreaches here in San Diego. Some of it is because the community clinics, the FQHCs, the federally qualified health centers, are so advanced and so mature that from a physical health perspective, the needs are being met. So there isn't as much of a shortage, if you would, as there are in some other areas. There are places like the Lawndale Christian Health Center and Christ House and other places around the country where faith and health are more actively integrated that I think have the potential of having much more of an impact than we are able to in either a purely secularized, high volume, you barely have enough time to say hello and get through the review of systems, let alone kind of try to establish rapport. And then the other thing, I guess I said one last thing, but there is more and more talk now of moving from volume to value, meaning the essence of getting reimbursed is not going to be based on how many things you do, but on the quality of the outcomes. I mean, right now, any of you ever been to like Ruth Chris or Donovan's, right? You can go to Ruth Chris and Donovan's and order a burger and it's going to cost you like 18, 15, 18, 25 bucks. You can go to McDonald's and get a 99-cent burger, right? The problem with healthcare today when it's purely volume-based is you've got McDonald's burgers and Ruth Chris burgers getting paid exactly the same. It's hard, but there isn't an integration of quality.